Hello friends, welcome to this session on cardiology, and our topic for this session is going to be something very interesting. Have you heard of a person being punched on the chest and suddenly falling down and collapsing all of a sudden and passing off and then passing out and then passing away? I guess you have heard. Have you heard of a person drinking on a weekend and then suddenly resting his arm on the chair, going off to sleep, and then suddenly and dies? I guess you have. Have you heard of a person playing football and then suddenly sweating such a lot, panting, gasping for breath, and then suddenly catches hold of his chest, falls down, and is spot dead, pulseless? Yes. All the situations which are described in front of you are one or the other of the examples of a broad purview, a broad topic, which we will learn very shortly. And the name is, yes, you've guessed correctly by now, it's sudden cardiac death. How do we define it? It is an unexpected death due to cardiac cause within 1 hour of the onset of symptoms. That is very, very important. And what is even more important, it occurs in a case of unknown or known cardiac disease. So a person has onset of symptoms, within 1 hour of that he dies, whether or not he has an underlying cardiac disease which is known. That is termed as a sudden cardiac death. Just jot it down. 4 important points. What are the 4 important points? It is an unexpected death due to a cardiac cause, of course, due to a cardiac cause within 1 hour of onset of symptoms. In a case of unknown or known cardiac disease. Right. So you need to understand something very pertinently, that I am saying that a person suddenly has a chest pain or maybe diaphoresis. He may or may not be known to have any cardiac illness, and within 1 hour of that he suddenly dies, suddenly passes off and then passes away due to a cardiac cause. That is your sudden cardiac death. But could you give me some common examples? I started the discussion with some clinical cases, some interesting clinical situations where you could cite this one common link between them, that is sudden cardiac death. But could you tell me more specifically, like what could be the answers to those questions which I gave initially? We spoke about an alcoholic who passed off and then passed out. Anyone with that answer? What is common in alcoholics? Dilated cardiomyopathy, yes, and which fibrillation? Atrial fibrillation. Then I said somebody was punched on the chest and collapsed. Yes, giveaway of the elastic and papillary component of the ventricles, the valves, leaflets, or maybe an induced arrhythmia during the later stages of the fast depolarizing action potential of the cardiac myocytes. Commotio cordis. Good. And the third case which I talked about, yes, the person suddenly having fibrillation and passing off, possibly could be WPW syndrome or HOCM, right? So all these cases we are going to discuss one by one, take them up in detail, whatever little detail is required at our level, and see that how do we manage them and how do we come across them. So the first one we will come across is your, yes, the commonest topic in our cardiology, which you are always interested about, myocardial infarction. Myocardial infarction, after the person has myocardial infarction, within the first hour, what is the most common arrhythmia overall, tachy or brady? Ventricular fibrillation. Very good. Ventricular fibrillation. within the first hour. And what is the commonest bradyarrhythmia? Mobius type 1, 2. Yes, Mobius type 2 heart block. Mobius type 2 heart block. So since we've had our discussion, or you will be listening to, whichever the case is, on the discussion about ventricular fibrillation, most of you might be knowing that we are going to go in for a defibrillation of this particular individual suffering from ventricular fibrillation. So the treatment is going to be AED. Now if it is a pulseless tachycardia, pulseless ventricular tachycardia, then of course you might have to start with CPR and rescue breaths and move over to AED, or automatic external defibrillator, wherein you'll be giving the person 120 to 200 joules of asynchronized DC shock in case of ventricular fibrillation, right? And Mobius type 2 heart block, I've already discussed this in the ECG section as well as in the block section, but still, just to make concepts a bit clear for you, if this is the SA node and this is the AV node, these are the bundles, Bachmann, Wenke, Bach, Thorel, this is the bundle of His, right? So, in that case, what happens is, if you have a block in the bundle of His, so it's an infranodal block, that is your Mobius type 2 heart block. And in such a case, of course, you would need a pacemaker. Of course, no need to say that, you would need a pacemaker. Right, so that is definitely the need of the hour. And what you would see in the ECG of this particular person is that you have a P, QRS, T, then you have a drop beat, and then you have a P, QRS, T. But this distance, this PR interval of the wave preceding and the wave succeeding, drop beat usually would mean you have a small p and then nothing to follow it after. So this is your drop beat. Let's use a red color. This is your drop beat. So the PR interval preceding that and the PR interval succeeding that will be equal. They are equal. So it is a Mobius type 2 heart block, right? Mobius type 1 heart block would have had this one longer than this one. And if you have a fixed ratio heart block, then you would see that for every 2 P waves or 3 P waves respectively, there would be one completed PQRST complex, right? So those are the different things which I just needed to hammer in your head regarding this first part of MI associated rhythmic disorders, which have been covered in detail in your MI section as well, the complications of MI. So I'll not go into details, but this is just the first two that we'll start with. The next one which we'll concentrate on after MI are going to be the cardiomyopathies. Cardiomyopathies. It could be a left ventricular outflow tract obstruction in the form of HOCM, or it could be alcoholic presenting to you with dilated cardiomyopathy, right? So in case a person has HOCM, again, this has been discussed. This is just a summary lecture of many different broad lectures. So in case of a hypertrophic obstructive cardiomyopathy, you have an asymmetrically enlarged septum, thereby narrowing the lumen of the left ventricular outflow tract, causing left ventricular outflow tract obstruction. And in that case, what you would find is the left ventricle would not be getting sufficient blood supply, leading to an ischemic ventricular fibrillation, especially the left ventricular fibrillation. So ischemic ventricular fibrillation. For which again you would require the same treatment, automated external defibrillator, give shocks, desynchronized shocks if required, or if you have nothing to start off with, CPR, rescue breaths, same protocol if it is a pulseless ventricular tachycardia. But usually see the spectrum which I've explained in ECG lecture also, pulseless ventricular tachycardia could go into a ventricular fibrillation, or the reverse could happen. If it is a shockable rhythm, shock it. If it is not a shockable rhythm, give CPR and rescue breath. Still it becomes a shockable rhythm, then shock it. That is as simple as I can make it for you in case of any cardiac emergency. What about, because there's no use of giving shocks to a flat line, right? So when I say pulseless ventricular tachycardia, it means the pulse is not there, but it is still a ventricular tachycardia. It is not a flat ECG. If there's a flat ECG, you give chest compressions, adrenaline if required, but don't give a shock, because we can give a shock to make an irregular rhythm regular. We can't give a shock to make a flat line irregular. That is not the dictum. So that is why listen to the lecture on ECG which I have explained in details about the approach to pulseless ventricular tachycardia and ventricular fibrillation and even bradycardia. You will get the idea absolutely clear regarding this topic, right? After that, I told you about an alcoholic person who's just boozing around and then suddenly passes off, and you see that you discover, if you do an ECG in that person, you will see that he too is suffering from a type of fibrillation, but this time the fibrillation is mainly confined to the right-sided leads in the near the vena cava junction, and in such a person what you would also find is that the P waves are not the typical P waves, but you have a specific absence of the P wave. When you listen to the lecture on the ECG changes, you'll see I've made a comparative table between atrial flutter fibrillation and multifocal atrial tachycardia. Over there you will see that different morphologies of the P wave are found in MAT, whereas flutter waves are found in atrial flutter, and absence of P waves are characteristic of atrial fibrillation. So in this person undergoing an alcoholic DCM, which we refer to as sometimes as holiday heart syndrome. In a holiday you're drinking and you have a heart attack, so I won't say heart attack, but then pathology affecting the heart, holiday heart syndrome. The cause of death over here becomes atrial fibrillation. That is the most important point. Atrial fibrillation. Right. So atrial fibrillation becomes the cause of the death over there, and you know, for any of these supraventricular tachycardias, we plant in an implantable cardioverter defibrillator. That's what we usually do. So the treatment is going to be implantable cardioverter defibrillator, right? So that is what is going to be your approach to these sudden cardiac deaths arising out of cardiomyopathies. Now the third thing we'll go to in our discussion are the pre-excitation syndromes. Pre-excitation syndromes. Again, I have discussed this at length in the ECG video, so I won't go into much details. Just a short thing. There are two syndromes, WPW syndrome and LPL syndrome, LGL syndrome. WPW syndrome, Wolff-Parkinson-White syndrome, you have an accessory bundle of Kent. Which bypasses the AV node and takes the impulse directly from the connecting bundles to the bundle of His, and thereby you have both these are characterized by shortened PR interval, short PR interval. But since there is intermyocyte conduction in WPW syndrome, so you will have wide QRS, so PJ interval remains normal, PJ remains normal, and you have a delta wave in WPW syndrome due to the intermyocyte conduction and an absence of the septal depolarization vector. But in case of LGL syndrome, you have the James bundle or Mahim fibers, and over there is a bypass bundle, but which goes and joins the bundle of His distal to the block. So over there you do not have a wide or splayed out QRS. There is no intermyocyte conduction, so there's normal QRS, and the PJ interval is shortened. It was just to draw out the ECGs for you. In a WPW syndrome, if this is the P wave, there would be a short PR interval, so this would be less than 0.12 seconds, of course, and you wouldn't have a Q wave, you would have a delta wave and then change in the gradient. This is R, S, and then a T. So you can see that PR is short, but QRS is played out, wide QRS. So PJ, which is PR plus QRS, this is the J point, right? This is the J point. So this remains normal. This is WPW. But what about LGL? In LGL, this is P. This is, you have a normal QRS T. So if this is short PR and normal QRS, so PJ is equals to PR plus QRS. Over here you are having short PR, prolonged QRS. Over here you are having short PR, normal QRS. So overall the PJ interval is going to be short. You're going to have a short PJ interval. That is a basic difference. And then I've discussed about the roles of different ablation therapies, abutylide, etc., and flecainide, and then you can do radio ablation of the bundle. You can visit and have a look at the ECG lecture for all that. I'm not going to details, but that is your approach towards the pre-excitation syndromes. And the next one we are going to discuss about is a bit rare, but it's in vogue nowadays. I've already discussed this in many other lectures as well. Brugada syndrome. Brugada syndrome, the problem is in a sodium channel by the name of SCN5A. Already said, SCN5A sodium channel is at fault, which leads to erroneous impulse generation in the right ventricular epicardium. As a result of which you might have ST elevation on the leads V1 and V2. ST elevation on the leads V1 and V2. You might be thinking I'm going fast with this, but this has already been discussed in individual lectures. So this is just a summary. That is why I'm being very deft and precise for your revision purpose. If you want to understand what all I'm saying, listen to the individual lectures which I have mentioned. You will get the entire purview of sudden cardiac death, because sudden cardiac death is just a summary of different subtopics. It is not a detailed discussion at length. I hope you're understanding that and can cope up respectively. Right. The next thing we'll talk about is Romanov-Ward syndrome. Romanov-Ward syndrome is also known as the long QT syndrome, which is the precursor sometimes of your Torsades de Pointes. So Romanov-Ward syndrome is the long QT syndrome, right? Long QT syndrome, where the QT interval is sometimes more than 450 to 500 milliseconds. Classically, you can say more than 500 milliseconds. Long QT, more than 500 milliseconds. Long QT syndrome, and predisposes to Torsades de Pointes. Different ionic imbalances can give rise to long QT syndrome, predominantly hypocalcemia along with hypokalemia and hypomagnesemia. So the treatment will be IV magnesium sulfate. The treatment is over here. Brugada syndrome, you know it, we have to place an ICD, implantable cardioverter defibrillator. Pre-excitation syndrome is ablation of the bundle. Romanov-Ward syndrome, Torsades de Pointes is going for IV magnesium sulfate, right? And after Romanov-Ward syndrome, the next thing we could talk about is this particular ECG which I have over here. Can you see the epsilon wave, this weird shaped, this I'm tracing it out for you. QRS complex, yes, this is the epsilon wave. This is found in arrhythmogenic right ventricular dysplasia. Right ventricular dysplasia. It was once one of the leading causes of sudden cardiac death. Now Brugada has come in the picture, and this arrhythmogenic right ventricular dysplasia, which causes characteristic epsilon wave, please don't confuse it with the J wave which is seen in hypothermia or hypothyroidism, right? So look very carefully. This is the epsilon wave. Epsilon wave in EEG, as I've already discussed, is found in deep stages of meditation. So we are not concerned about that. But epsilon wave in the ECG is particularly found in ARVD. There is arrhythmogenic right ventricular dysplasia, and the treatment, of course, would be ICD. Any tachyarrhythmia, usually go in for ICD, right? The next thing, commotio cordis. Commotio cordis, to explain it better, I think I would draw a diagram from physiology. Commotio cordis. Commotio cordis, what happens is somebody lands a punch on your heart, and usually that external mechanical trauma coincides with this particular phase of your fast response action potential. What are the phases? You have sodium coming in over here, you have potassium going out over here, transient depolarization, you have potassium going out plus calcium coming in. So there's this plateau phase, and then you have excess potassium going out. So this is the entire purview. If you have landed a punch in this area, the late part of the plateau phase and the early part of the delayed repolarization phase, what happens is this is the most vulnerable time of this cycle of ionic exchanges, where if you land in some external impulse, there is a chance of arrhythmogenic potential. So this arrhythmogenic potential, what is going to happen is, at this particular phase, if most of the cardiac myocytes are there at that particular point, when you've landed that particular impulse, punched him on the heart, then the heart has a chance of going into electromechanical dissociation, and there would be an ectopic potential generated, which is going to result in this particular deadly arrhythmia, the mortality of which is very high, and this entire event is termed as commotio cordis. But yes, of course, everything has a treatment, so you need to know about the treatment aspect as well. What you need to understand is that in such a person, of course, it is an arrhythmia, and it is most possibly an irregular arrhythmia, so you will need an AED, automated external defibrillator. But along with that, usually it happens in a field of play, you will not get defibrillators over there, so at least start with the CPR. That is the message. Start with CPR and add on AED. We've already spoken about arrhythmogenic right ventricular dysplasia, so I'm not going into details with that. We make this 7, then our number 8 is Takotsubo cardiomyopathy, which we've discussed in different discussions. It is an acute onset cardiomyopathy due to increased sensitivity of the heart to the catecholamines in times of severe stress. Like suppose a woman has lost her husband, and suddenly she develops chest pain, diaphoresis, and you do an ECG of the heart, you do, see that there is an ST elevation, and then suddenly you do an echo, and then you do cardiac biomarkers. After that, you find there's no MI, right? And the ECG also does not give you absolute corroborations, but if you do an echocardiography, what you finally find out is that person is having an outpouching of the left ventricle, which looks like the head of the octopus, which I have already discussed in my previous lectures. So in that case of a Takotsubo cardiomyopathy, or I think a question came some years back, a woman was trapped in a lift and elevator, and what do you do with that? She's so scared, she can't get out of it, and suddenly there is an upsurge of her hormones, and this increased catecholamine levels in the body, and her heart is also sensitive to these catecholamines, results in precipitates an arrhythmia, and that is nothing but your Takotsubo cardiomyopathy. The ECG and findings of your cardiac biomarkers are not really conclusive. Biomarkers are definitely absent, and ECG may give in tall T waves on ST elevation, but definitely not pathological Q waves mostly. So you are uncertain with your diagnosis, you don't know what to do. Then if you do an echocardiography, you get this octopus head like bulging out of the left ventricle, and you know, yes, there is Takotsubo cardiomyopathy, the woman is suffering from this, and then you fall under the definitive treatment, which is diastolic counterpulsation using an intra-aortic balloon pump. As you can see, this pump which you insert inside the aorta, see, right, and with this you are giving a pulsation in the phase of the diastole. Why? With this pulsation which you are giving when you are inflating the balloon, it is generating sufficient force enough which will cause the heart to spontaneously pump out blood through the aorta in the phase of systole. During diastole, you are inflating the balloon, you are giving a counter pulsation which energizes the heart enough so that it can give a recoil and pump out blood in the phase of systole when the balloon is collapsed. Learn it easily as a concept like this. all they might ask you is what device is used. Is an IABP, intra-aortic balloon pump, in Takotsubo cardiomyopathy. And that basically completes our discussion on sudden cardiac death. I have discussed about the different ionic imbalances, the different cardiomyopathies, the different post-MI cardiogenic arrhythmias, the Brugada syndrome, but then your Romanov-Ward syndrome. Then of course we had Takotsubo cardiomyopathy and ARVD. All these are more or less a commotio cordis. All these are more or less what you need to know about sudden cardiac death. And I hope this discussion was helpful. Of course, if you have doubts, you're always welcome to inbox me. Till the next session, thank you.